Hi, everyone. Thank you for joining. We will begin momentarily. All right, Dave, would you like to kick us off?
Sure. Thank you, Karen, and welcome everyone. And looking at the attendees, I see many familiar names and a number of new. So welcome everyone. Karen, let you go to the next slide. So those are new to Connectathons, especially to virtual Connectathons. All tracks have a orientation on our objectives, and also for those who are new to virtual Connectathons, some important information on how to participate and how to connect through the HL7 resources. So we'll be covering that as well. Again, especially important for those who have not participated in HL7 virtual Connectathon in the past. And then also summarizing report outs from the track. So Karen, next slide, and the next slide. So let's start off with an introduction to our team members, a very brief introduction, and then an overview of the track. So first of all, I am Dave Carlson. I've been participating and leading, actually this will be more than 10 care planning Connectathons I've organized for more than 5 years. So familiar with a number of names here and happy to be back virtually. Emma Jones, would you a brief introduction to yourself?
Hi, everybody. My name is Emma Jones. I am Director of Interoperability with EMI. I am also a patient care work group co-chair. And one of our projects in the patient care work group is the care plan domain analysis model. Those are one of the projects that I actively participate in. And I've also been working with Dave on multiple Connectathon tracks that has to do with care planning. Welcome.
Thank you, and Gay, I see you out there as well.
Did you say me?
Yes.
Yeah. I couldn't quite hear you. Let me turn my volume up some. So I'm Gay Dolan. I'm a longtime HL7er, nurse by background, and actively involved in this project as a technical care plans, me and nurse, and I am working with them on the fire IG development.
All right, thanks, Gay. And Sean Muir, I think, is not yet able to join us today, but Sean Muir is also a core member of our team and a longtime participant in HL7, fire standards, CCDA standards. So Sean was working with us in the development of reference applications for care planning. Karen, could you introduce?
Hi, everyone. My name is Karen. I serve as the project manager for the Multiple Chronic Conditions eCare Plan project, and am serving as track support for logistics, administrative, etc. On this care planning track. And I'll hand it over to Savannah.
Hi, good morning for, I believe, just about everybody. My name is Savannah Muller. I am serving as the project analyst for the Multiple Chronic Conditions eCare Plan track. I am also working in a support role to support the track leads and the SMEs in putting this Connectathon together and just for the overall project. You'll probably be getting some emails from both me and Karen, and if I message you, I am taking minutes or just notes today. So for attendance, that is why. I guess back to you, Dave.
Great, thanks, Savannah. So let's jump into it. So track description. So this is hosted by the MCC eCare Plan project. And as the name suggests, really focusing on patients with multiple chronic conditions and better supporting shared comprehensive care planning across the team for patients with multiple chronic conditions. This project is sponsored by both the National Institute of Health and as well as the Agency in Healthcare Research and Quality, AHRQ, and supporting the development of an implementation guide, which is a multi-year effort, as well as reference implementations of some applications for patient and provider engagement in their care planning, but in the context, as Emma introduced, as also in the context of the patient care working group and the longstanding efforts on a domain analysis for care planning and really building on years of effort in that area. So over the past 2 years, roughly, this track has focused on the MCC eCare Plan project, including as part of the sponsored support in developing Smart on Fire applications for both clinician and patient-facing engagement in contributing to sharing and better understanding their care plans for the complexity of multiple chronic conditions. This track, you can say, it does build on a longstanding engagement, including say more than 10 care planning tracks over the past more than 5 years. So we tend to continue contributing to our shared community in this space, supporting the development exchange of care plans. So also evidence-based guidelines. So there's active collaboration with other projects, both at AHRQ and elsewhere, to bring in computable evidence-based guidelines, contributing recommendations for patient care and better understanding how those recommendations are contributed into or influence the development of care plans. So it's an active part of this project overall. Also, the link at the very bottom of the slide deck for recordings from prior track in May of last year. There's also from the Confluence page at HL7 introduction from many of the prior tracks as well, but a focus on this track and its relationship and hosting by the MCC eCare Plan project. The other thing I want to say at kind of an outset right now, as well as we introduce this, is that Connectathons are really intended by the HL7 community and really emphasizing community participation. It's a dialogue among all participants. It's been a bit more challenging to at times get that active dialogue and exchange in a virtual environment, but I'd like to emphasize that right now, including during this overview itself. After we get through a few of the intro slides, I really do want to open this to input from others. Most we had time to go through every one of the individuals on the call and better understand your perspective and an interest in care planning. But as we get the latter part of this presentation, I do want to invite more open discussion and absolutely the same during the Connectathon itself. It's intended to be an exchange and a dialogue. So next slide, Karen. So goals, the track goals are during this meeting to focus on care planning goals. I'm going to describe goals as what should be and is a central part of care planning for patients, often not explicitly stated in an interoperable way. It's been an active part of discussion within the HL7 patient care working group and that analysis. So this track is to focus on better understanding the state and the use of interoperable goal-oriented care planning. So the goals also to emphasize the patient engagement. These are not only goals created by the care team for clinical purposes, such as managing systolic or diastolic blood pressure, but it absolutely intends to better support patient engagement and creating and defining personal goals, lifestyle goals that are so important in many chronic conditions such as hypertension, diabetes. So better understanding and supporting the patient's active participation in creating and supporting and understanding their role. The other aspect of exploring this is not only the goal resource as defined by FHIR, but even particular emphasis on the relationships and the interrelationships of those goals with conditions or assessment observations that those goals are intended to address. There are relationships defined in the FHIR standard. Part of the track in this meeting is to understand only the use of those relationships as defined in FHIR standard, but bringing that into applications and in care coordination processes on how those sorts of relationships are and should become more visible and managed. Other aspects of relationships are the assessment observations, and we'll talk a minute here on social determinants of health, on assessments related to SDOH or other aspects of patient care, and how those assessments influence goals, as well as looking at the outcomes and tracking and monitoring the progress toward or lack of progress toward goals. Again, other FHIR resources, particular observations or procedures that assist us all, distributed team in better understanding the state of a patient's care. So looking at some specific aspects in the representation of these shared goals and then the terminology underlying this as well. Also, in the last point on this slide, I suspect that many of you have heard about the notion of SMART goals, not to be confused with SMART on FHIR, entirely different acronym. This acronym of SMART, of specific, measurable, achievable, relevant, and time-bound goals, is a often used guidance for how to create effective goals, not only in healthcare, but the same acronym and idea is often used outside of healthcare industry, including objectives for employees in an organization. But yet these are increasingly referenced and cited as guidance for creating healthcare-oriented patient goals. So part of our objective this meeting is to better understand concrete examples of these SMART goals, how they're represented, how they're exchanged, and how they influence the creation and management of care plans. And then finally, the relationship of the US core and the evolution of US core in the version 2 US CDI, and looking at search parameters or expanding on the ability to search for goals and their relationships. Next slide, Karen. So scenarios, we've defined in this track, and these are all explained in somewhat more detail on the Connectathon page, but define 3 clinical scenarios, social determinants of health. We'll go into that in a bit more example during this overview, and there's more detail on the Connectathon page. So in particular, aligning with the US core expansion and inclusion in their draft current build of profiles and value sets, specifically associated with social determinants of health as constraints on goal, condition, observation resources, but also including ongoing work with Gravity in their guideline for social determinants of health, and understanding the relationships of those guidelines and the relatively new content added to US core, and this track focusing on how those contribute to and are included within a shared care planning process. Also pain management. There may be a number on this list today, and some who will be participating in a Connectathon itself, who have been actively engaged in other AHRQ projects around chronic pain management, including pilot testing, smart and fire apps, and engaging patients in shared decision-making. So drawing some specific examples and lessons learned and challenges out of that ongoing work, and focusing it on the care planning and goal aspects, and particularly engaging patients in shared decision-making around the chronic pain. So that's another scenario. And then diabetes and goal progress, and tracking the definition and progress of patients toward their goals in diabetes. So those are 3 scenarios that we'll be focusing on. We've built some sample content, and the notion of the Connectathon really being a dialogue and exchange, absolutely welcome communication before the Connectathon, and certainly during of other work that you all have underway in associated with these scenarios or other related scenarios that these patients might be experiencing. So next slide, I'd like to ask Emma to, actually I'll step through part of this quickly and then transition to Emma. So the SDOH scenario. So first of all, as we've introduced on our Connectathon page and have used a number other aspects of our project, is a patient, a fictitious patient scenario, a patient named Patricia Noel. So in this case, a thread of her activity specifically tied into social determinants and how those contribute to her planning for, along with her other multiple chronic conditions. So in this case, these links, and this is also directly as is on the Confluence page where you can follow these links, but tying into specific examples from the Gravity implementation guide and the US core work, but a hunger vital sign questionnaire, the results of which are captured as observation resources with profiles and value sets defined. So looking at specifically the SDOH screening and response observation, which then in turn is used as the evidence for creating an SDOH condition for Emma's condition of food insecurity. But then feeding this into the definition of a goal-oriented care planning and creating a goal that addresses that condition for food insecurity, and then tracking that goal and its associated progress as part of Patricia's care plan, all throughout emphasizing the fact that Patricia has, in addition to these social determinant concerns, ongoing management of chronic kidney disease, hypertension, and chronic pain. So we've had created for this specific scenario, all consistently tied into Patricia Noel's broader use case, some sample FireR4 resources which are available on a GitHub site, and also loaded into a Fire Sandbox that will be part of our connected environment. So now, next slide, and I'd like to ask Emma to review some of the process around goal-oriented care plan.
So thanks, Dave. So as Dave explained, goal is an integrate part of care planning. When we talk about goal, we're not just talking about the goal resource alone by itself. We're also taking goal into context of all its interrelationships and things that it's related to. Goal is very important because by assessing your goal is how you know if your interventions are working and if if your condition or your observation or whatever the health concern is if it's going to improve or if things will get worse. So some of the things that we hope to tackle during this Connectathon is to tease out specificity around goals. Things like, is there a difference between patient perspective of a goal or a clinician perspective of a goal? How a goal links to other goals, for example, and the relationship between goals and interventions and health concerns. Also, progress of the goal. Is the goal progressing? Is it getting worse? Are there any barriers to goal achievement? So those are some of the things that we want to look at during this Connectathon in relationship to goals. One of the things that we also do at HL7 is this track is very important to some of the work that patient care work group does. When it comes to the care, we're currently in the process of updating or writing a second version of the care plan domain analysis model. So some of the work are things that we get out of this track, the findings that we find. And that's why we really, really want people to participate and be engaged, give us feedback, let us know, and also taking things from a clinical perspective as well as the technical perspective, the patient's perspective, the caregiver perspective, everything that that will make this track successful. So Karen, can you go to the next slide? So if this image and what we did with the next slide is actually plugged in some data so you can see where it is goes for in context of pain management, the things, how the pieces fall together when the patient has a health concern that is related to pain and interventions that come into play, and how you measure your goal to see what your outcomes are. Is it working? Is your intervention working or not working? So those are some of the things that we will go, and we're doing this in various scenarios, as Dave mentioned, an SDOH scenario, diabetic diet scenario, and with the pain management scenario during this track. Next slide, please, Karen. I think that's all I have.
So we've got a number of sessions organized. So these are in Whova with links then to specific times. So I'm not going to walk through every detail of these, but I want to focus on just a couple of highlights. And then before we have a number of slides that provide a summary of some logistics around participating. But before doing that, I do want to turn around and open to any questions or really input from you all on the list here as well about what your interests are, and hopefully find some other shared interests of those who are on the call today or will be at the Connectathon. So a couple of highlights. First of all, the second item on this slide noted in the beginning that there is an HL7 project and an implementation got underway around identifying data elements, value sets, and guidance in general around care planning for patients with multiple chronic conditions. That's a multi-year effort. It started with chronic kidney disease and being expanded in other domains, including diabetes, cardiovascular disease, and then new work starting now to identify data elements around long COVID. So these are all part of this effort. So we have a session where Emma and Gay will walk through the current state and also some of the roadmap around that implementation guide work. And then goal relationships. So as we described here today, really digging into not only review of the standards, but especially any systems we have to test, demonstrate sample data associated with these relationships around goals. Then coordinated specifically with the US core track. We intend to join, still the details just to be finalized, but our expectation is that this joint session will be hosted by US core to join that group and specifically look at the profiles and work in the current build draft around social determinants and emphasize and discuss some of the scenarios that we highlighted here a few minutes ago. Then we have another work session. We have these 2 general work sessions planned. Again, really want to engage, all of you who have an interest in not only interest, but any systems, applications, sample data, questions. So really a number of active working sessions. But one session here, we want to highlight some work, and I see, we have a number on the call here today who have been part of this effort. But specifically, so part of our project is pilot testing our Smart on Fire applications, both patient and provider facing. We're pilot testing those at Oregon Health Sciences University, OHSU, in the Portland area, integrated with Epic. And so as part of that, they have created in Epic a scenario for Patricia Noel and an attempt to share that for testing outside of their system, exported that to a CCDA document. So that provides directly related to care planning for Patricia Noel and looking at tools and coordinated work with other HL7 on mapping and transformation between CCDA and fire. So we'll look at some concrete examples of work to automate the transformation generation of that fire resources and the current state of that work. So Ken Lord, Sean Muir, and others will be discussing that. So very relevant to our care planning and our pilot work. Smart goals, we've talked about, time to focus in on some examples of that. SDOH working session, the third from the bottom is the one we described, which this is really a working session to dig into some of our details. And then cross track, we are going to be reaching out and inviting across many other tracks that have an interest to join in a shared session. So there's some of our plan sessions here. I'd like to take an opportunity now, just and then have to make this a dialogue. Any questions, I guess, first of all, from good number of people on the call now. No questions. How about just a comment about your interests, perhaps as they relate to this, or how you see might extend this work?
Yeah, this is Dave. This is Daryl Welk.
Hi, Daryl.
With Green Room Technologies, and we're a consulting company. Our clients are mostly startup companies, health and medical devices. And I've sort of been tracking the care planning work over the years. And I'm really interested at this point in how we can leverage the multiple chronic conditions care plan work you've been doing in a couple of areas. We have some clients in the direct-to-consumer, direct-to-patient virtual care world. And so they sit kind of outside of the normal clinical, although there's a lot of interaction there. Just how we can leverage some of the work that's going on here with those types of companies. And the other area is working with some pharmacy vendors and who work with the pharmacist eCare plan, which has evolved, has touched on some of this work and is kind of going in parallel, looking for scenarios where we can involve pharmacists in the multiple chronic conditions. So both of those are kind of, along the lines of how we can leverage this and take care planning out of the traditional clinical areas into this evolving virtual care direct-to-consumer world. Oh, and I find the pain management, I think it might be an example, good example I'd be interested in, how that works with physical therapists in that kind of in that world.
Good, thanks for the pain management. We expect participants from some ongoing pilot work over the past 2 years, and part of the shared decision making was, again, toward your last point, bringing in patients' input as to what other treatments they are pursuing. And as to your first point, where the patient is not an aside in care planning, but from the beginning an integral part of care planning, including better understanding what other treatments they are pursuing that their core clinical team may not be aware of, such as physical therapy, acupuncture, or many other alternative treatments. So yeah, bringing the patient into the center is a core interest of our group. Thanks, Daryl.
Yeah, it's very interesting. Thank you.
Dave, I have a question is, and just, trying to learn and understand more about the work that's already been done and everything. With these eCare plans, a lot of vendors, EHR vendors already have care plans themselves in their EHRs. And now we're working on sharing that across systems, correct me if I'm wrong, which is what the eCare plan is, so that we have the interoperability of the care plan. My question comes more to versioning and architecture, in the sense of how is it planned to be modeled kind of like medication reconciliation, that you would receive someone else's eCare plan and then have to rectify it with what you have within your own system aspect? Is that the model, or is there or is the model more that some certain place would hold the master, and you would ping the master eCare plan for that patient, everyone would, to have the most recent? So how do you deal with those, I'm going to say that versioning and that difference across, to know that you are getting the entire picture?
Well, all good questions, Linda. I guess I would, in fact, part of the counter is, hey, how do we all deal with that ongoing challenge? And part of which is the care plan, at least what I've seen and heard from both pilots and look at some vendor systems, is often a text-based summary of a patient's care plan. So part of a core of this work of the MCC project is to define the discrete data elements that care plan or care plans are composed of. So the MCC eCare Plan project, a core objective is to identify the data elements from a technical expert panels organized by the NIH, to identify the data elements in each of the condition areas of our focus. We have chronic kidney disease, diabetes, cardiovascular disease, new work in long COVID. So identify the data elements from, and data elements being fairly broadly interpreted of the labs, the vital signs, the social determinant factors, and other aspects that are contributing into their care. So I guess I come back to your question, is not only looking at each care plan as being a separate document, but composed of and defining the standardized data elements within those. And then the second part of, at least part of our ongoing pilot work, is consider that by sharing the data elements that a care plan or care plans are composed of, we're sharing the elements of care planning and not necessarily, or not only, these sort of composed documents of a care plan, and it's an ongoing evolution. I know that makes sense to you, Linda, but really kind of looking at the discrete elements within care plans, and not only as a document-oriented view.
So Dave, this is Ken Lord. I'm also really interested in what Linda was talking about, sort of at that higher level of ownership and authority and latency and custodianship as it relates to multiple elements of a care plan, and multiple care plans within a larger patient-centric care plan.
Like touching on both Ken, what you and Lynn described is part of the challenge that we've learned through our discussions as part of the HL7 community is the often specialist-oriented nature of a care plan for cardiology or a care plan for endocrinology for diabetes or a care plan for pain. But a patient, doesn't necessarily care that, or I shouldn't say don't care, but they need to understand and solve their holistic health challenges. And so how do we look at, again, the elements of these different perspectives, not as separate care plans, but as elements of a whole, and then share those elements. So that's a kind of broadly from a philosophy point of view of a direction.
So basically, if I'm understanding it correctly, your goal is to create the infrastructure around the concept of care plans and the interoperability of care planning for a patient. And then hopefully that infrastructure then can be applied to any type of domain, whether it be a clinical specific domain of a particular disease or a professional type of different domains, for example, physical therapy or various other social determinants of health, anything like that. But to build that standard language and structure by which any type of information could be shared. And then you're just using those examples of the kidney disease and diabetes and long COVID as examples of inputs into that overall care plan.
So I'd say yes, but those examples are more than examples. It's actually several years of effort by technical expert panels, TEPs, that have been assembled by NIH with a substantial team of industry experts in each of those domains. So tend to be more than examples, but the deep analysis. And then I guess the second, because part of the comment is really that is an essential core of the MCC eCare plan implementation guide effort by HL7 is to standardize the value sets, terminology, profiles needed for those data elements. Each of the data elements identified by these technical expert panels, but creating the standards and the terminology associated with those data elements so that we can have the interoperability of the elements contributing to comprehensive care planning. And anyone else with input on that too from,
Yeah, this is Emma. I just wanted to add, yes, Linda, I think you're exactly correct. But then also not only the specific domains, but the generalized domain. If you generalize all of those specific domains, because you have to take it from the patient perspective. All of that's what you just mentioned may be happening to the same patient. And how is the patient managing all of those? The diabetes care plan and the cardiology care plan and the kidney disease care plan. So all of those things have to be managed from the patient perspective by the patient all at the same time. So a way in which to align those domains and to make sure things do not conflict, or patient goals are aligned and the care providers are coordinating and communicating, with the patient in the middle. So so we're trying to lay the groundwork down to be able to do these things, and hopefully in a seamless way that can be used regardless of what domain it is.
So Emma, just one little point on that, and sort of just a perspective. I think patient is a role of a person, and sometimes the patient is the case manager for themselves, but in many cases there's somebody who's the case manager, elderly people, children. stuff like that, people like that, where the case manager is not the patient. And so that's just a view of some of the things we're trying to do. That's all.
Yeah, yeah, exactly. The case manager can be a caregiver. The case manager can be a formalized case manager or care coordinator. Yes, definitely.
Any other general thoughts either in your interests, your work, or questions about what you'd like to see?
I guess the only other question is, and I know, I'm reaching for the sky, right? Looking at that greater vision of what's the ultimate end goal in the perfect world once this happens, knowing that it's going to take long time to get that way, but at least having that in front of everything. And so that just kind of goes back to that, okay, if we have this centralized new methodology, right, in way of that, this is the problem we all face in each of our types of things. How do we keep knowing as we're sharing the information where the truth is, right, when there's differences, aspects of that. So that's where I really think it's going to have to be a whole community effort, across the IGs, across all of these things. So I'm so glad that we're able to learn about other areas to see how do other areas solve that $1 million question and problem.
Or haven't solved it, as the case may be, and
Right.
the challenges we're facing, and how can we come together as a community to make progress?
Yeah. And then not going into the technical how, because Dave is like, one of the things that we have talked about in FIRE, using the subscription to be able to subscribe to updates. But then the other thing is, where is this thing at so that you can be able to subscribe? And this is where the community comes together and decide, this is how this is set up. And it might be a situation where different, there are different policies for different situations, and those kinds of things have to come into play. But I think technically there's the how to do it, but the policy around how to implement this is something that the community has to come together about.
So Laura, I see you've raised your hand. Floor is yours. You out there, Laura? I see you raised your hand. Was that an intentional raise?
Yes, I was double muted. Sorry. Thank you, Dave.
That's all right. Welcome.
Yeah, thank you. And I'd like to answer the question as well, because I know I've worked with you and Emma for a long time on this, and I also know Linda for some other cycles. But I just wanted to share also that this work is so very important, because many of us look at, these FIRE pieces are the very foundational Lego blocks. And some of the things that are being discussed as far as, how it gets implemented and things, we need to make sure that these Lego blocks will work for this bigger vision at this very foundational level. Some of those things, like Emma just said, policies and some of the implementation rules and the data ownership and where does it live and how do we know it's the most recent and things like that, huge questions out there, still work to be done. And I know that, lots of people are hitting this problem in all these different areas. And so just to kind of help this work, this piece, this event next week helps us know that if we get all those other things solved, we will have some solid building blocks that we can use to help make it work. So just to kind of help put it in context. Thanks.
All right, thanks, Laura. Any other comments? If not, you can transition to the next slide. If you do have anything else, certainly be an opportunity to do that yet. But Karen, you want to come walk through some of the logistics on coordination? I think we have coming up.
Sure, happy to. And I think that most of this information is already available in other places. So I just wanted to flag that it will also be included in the slides that we'll post on the Confluence page. But there's a registration link, I believe. You all have registered in order to attend this orientation. But the Zulip chat, we do have a topic opened under the Care Plan Care Coordination stream. So be sure to use that to communicate during the Connectathon. And then some contact information and additional resources just linked. And then we will also be collecting information to report out throughout the 2 testing days. So we will share around a Google sheet, and it'd be great throughout the sessions if there are interesting findings that you've uncovered, screenshots, or anything you would like to contribute. We will post those links in the Zoom chat during those sessions. So that will just help us make sure that we are sharing information and reporting on it toward the end. Some more links. And then in the appendix, we just have a few slides for folks who may be newer to care planning that could be helpful background, and then some general slides around the Connectathon. And that is it for our orientation call.
So anyone who is a first timer, maybe more to a Connectathon or even more so to a virtual Connectathon, there are some logistics by how HL7 organizes that. Feel free to reach out, especially to Karen, Savannah, or any of us on understanding how that works.
All right. If there are no further questions, we can give everyone a few minutes back. And yes, feel free to reach out to any of us. All of our contact information is on the care planning track page. All right. Thank you. We look forward to next week.
Thanks, everyone.
All right. Thanks a lot for joining.
Thank you.
Thanks. Bye.